The present topic of discussion, it is on bone diseases which are seen in oral cavity. So this is a part 2 of the discussion wherein we will be discussing about Paget's disease, cherubism, cleidocranial dysplasia and Marfan's syndrome. So firstly we will be seeing about Paget's disease. So Paget's disease, it is also called as osteitis deformans. Actually, this was named after a British surgeon named Sir James Paget in 1877, who described this osteitis deformans. Actually, Paget's disease, it is a chronic progressive disease of the bone, which is characterized by abnormal and excessive remodeling of the bone. That is, there will be remodeling will be different. That is abnormal. That is, both formation and resorption of the bone will be defective. So they said like it is mainly the defect of osteoclast, but actually the whole sequence of Paget's disease, it goes in 3 stages. That is lytic phase, wherein increased osteoclastic activity will be there. Next will be mixed lytic and blastic stage, wherein both osteoclastic and osteoblastic activity will be there. And finally there will be sclerotic phase, wherein there will be increased osteoblastic phase. So all these lytic and blastic phases which are irregular results in this abnormal and excessive remodeling of the bone. So how is this abnormal remodeling is occurring? So what is the reason? So that's what we are going to discuss in etiology and pathogenesis. So actually the etiology is unknown, but there are some genetic and environmental factors which are said to have been playing a role in the pathogenesis of Paget's disease. Initially genetic cause, that is because of germline mutations in a gene called as sequestosome 1 gene. So this sequestosome 1 gene and then next is there is a viral etiology, that is paramyxoviral etiology is said in Paget's disease, wherein osteoclasts said to have inclusion bodies of paramyxovirus within them. And the next is the patients who are with Paget's disease showed increased vitamin D receptor binding affinity among osteoclasts. So all these 3 factors, what they showed is they resulted in increased Rankel activity as well as increased interleukin 6 activity. So what does this Rankel and interleukin 6 will do is like they increase the activity of osteoclasts. So there will be, what does osteoclasts do further? Bone resorption. So because of increased osteoclastic activity, there will be increased bone resorption, that is mainly responsible for this lytic activity in Paget's disease. So what are the clinical features that are observed in Paget's disease? Actually, it is a disease of elderly individuals, that is, it is seen after 50 years of age. And here basically axial skeleton is affected more. Axial skeleton, so wherein we will see defects of femur, tibia, skull, pelvis and spine will be seen. And here the most common complaint in Paget's disease is bone pain, so which worsens a lot at night time. Okay, and sometimes because of this lytic activity, there will be formation of softened bone at the base of the skull, which may result in platybasia. And when facial bones are involved in severe cases, there might be other complications like headache, paresthesia, hearing loss, optic nerve atrophy, blindness, neuralgias as well as facial palsy can be seen as general clinical features. Now let's see oral manifestations in Paget's disease. So here under oral manifestations, actually both the jaws are involved in Paget's, but maxilla is comparatively more, it shows more incidence than mandible. So if we see in the jaw bones, there will be progressive enlargement of the jaws, and this progressive enlargement of the jaws results in widening of the alveolar ridge as well as flattening of the palate, as you can see in the second picture, where there is widening of alveolar ridge is there and flattening of the palate. And if you see in the first picture, because of the enlargement of the alveolar bone, there is spacing between, excessive spacing between the teeth also. If it is an edentulous patient might complain of tightening of the dentures also. So these are the various oral manifestations that are seen in Paget's disease patients. So now let's look into radiographic features. So radiographic features we will see according to the stage. that is as we have discussed earlier, lytic or mixed or sclerotic phase. So in the early lytic phase, lytic means osteoclastic activity, right? So we will see numerous radiolucent areas will be seen. So these radiolucent areas can be seen single, multiple or diffuse. So if we take a skull radiograph and see, as you can see in this present picture, there will be isolated lesions within the skull, okay? So this isolated lesions within the skull are called as osteoporosis circumscripta. And after early lytic phase, it is followed by mixed radiolucency and radio opacity. Because of radio opacities here and there, it will result in patchiness, and then followed by predominant osteoblastic phase, wherein there will be high amount of radio opacities which will form, that is patchy opacities are very high. So it gives an appearance of cotton wool appearance. This is a peculiar feature of Paget's disease, as you can see in the second radiograph, that is intro IOPA, wherein between the teeth you can see that cotton wool appearance of the bone. So that is cotton wool appearance. Other than that, jaw radiographs also show loss of lamina dura as well as generalized hypercementosis of the teeth. So these two are important features in jaw radiographs that are seen in Paget's disease. So next is laboratory findings. What are the laboratory findings that are observed? So initially, the important feature is that there will be elevated serum alkaline phosphatase levels. Okay, this is a very important feature where the alkaline phosphatase levels may go as high as 250 Bodansky units also. And as there is this resorption of the bone, so resorption of the bone because of which there will be so much of collagen which will be released into the urine. So collagen is made of hydroxyproline and lysine, right? So because of which urinary hydroxyproline levels will be increased. Along with that, there will be other collagen products that are seen in urine, like urinary excretion of pyridinium collagen crosslinks, N-terminal telopeptides and alpha collagen C peptides. So all these collagen products, they act as sensitive and specific markers of bone resorption in Paget's disease. So other than lab findings, we can even do histopathology, that is biopsy, and observe it under the microscope. So here also histologic findings we will see under three different phases. So in the initial osteolytic phase, osteolytic, right? So extensive resorption of the bone will be there. So whenever there is bone resorption, we tend to see numerous osteoclasts. So here the osteoclasts will be comparatively bigger compared that of the normal osteoclasts. So these osteoclasts, they are the multinucleated giant cells wherein it contains almost as numerous as 100 nuclei. So this is about initial osteolytic phase. In the next phase, there will be gradual bone formation, right? So this resorption will be converted, that is clastic activity will be converted to blastic activity. So because of which numerous reversal and resting lines will be there. These reversal and resting lines show the remodeling of the bone. So here there will be numerous reversal and resting lines because the activity will be very much abnormal. So these presence of numerous lines gives the appearance of jigsaw puzzle or mosaic pattern. So here if you see in the microscopic picture, the arrow is pointing towards that numerous lines within a bony trabeculae. So this is jigsaw puzzle or mosaic pattern. And next followed by the last phase, that is osteoblastic phase, where it shows dense sclerotic compact bone. So this is about Paget's disease. Now let's see another important disease, that is cherubism. Cherubism, it is also called as familial fibrous dysplasia of jaws, familial, okay. And here in cherubism, the main feature will be bilateral symmetrical enlargement of both maxilla and mandible will be there. Because of this bilateral symmetrical enlargement of maxilla and mandible, the child will appear to have chubby appearance. So this chubby appearance in Roman art, it is said to be cherubs. So here is a picture of a cherub where showing chubby appearance of the cheeks. This is the Roman art, because of which this disease is named as cherubism. So here, as I told you, it is familial fibrous dysplasia of jaws, right? So here the inheritance pattern is autosomal dominant disorder. So wherein the mutation will occur in the gene SH3BP2, which is present on chromosome 4. Actually, this SH3BP2, it has a tendency, it is helpful in genesis and maturation of osteoclast. So because of the mutation in this gene, there will be this osteoclast genesis and maturation will be defective. Other than that, there will be overexpression of proteins that are responsible for both bone remodeling as well as inflammation. And because bone remodeling as well as inflammation are defective in case of this disease, they result in multiple cyst-like growths within the jaws, and this is a disease of jaws alone. So these numerous cyst-like growths are seen within the jaws, that is maxilla and mandible. So because of these cyst-like growths, this cherubism is also named as multilocular cystic disease of jaws. So there are two names now: familial fibrous dysplasia of jaws and multilocular cystic disease of jaws. Now let's see the clinical features. As I have already told, there will be bilateral expansion of maxilla and mandible. As you can see in this kid, that is a child where that chubby appearance is there because of the enlargement of both maxilla and mandible, and you can see the eyes also. You can see the bottom sclera. So this is called as eyes to heaven appearance. So this expansion of both maxilla and mandible and eyes to heaven appearance, these are the predominant features that are seen in cherubism. And because of this expansion of the maxilla, the patient might experience respiratory obstruction, impairment of vision, as well as hearing impairment also can be there. And along with these features, there will be cervical lymphadenopathy also, that is enlargement of the cervical lymph nodes. Altogether, they might give that full moon appearance to the face. So one more important, and here like oral manifestations, if we see in these patients, as you can see in the picture, there will be narrowing of the maxillary alveolar ridges, because of which the shape of the palate will become V-shaped. And as you can see, not all teeth are present, so multiple missing teeth will be there, especially molars, they will be missing. Okay. And one more important feature of cherubism is that it is a self-limiting disease. That is, during childhood, there will be enlargement of both maxilla and mandible, and this enlargement will be there only till 5 years of age. After 5 years, the enlargement will slow down, and then it stops at 12 to 15 years. And once the individual reaches puberty, the lesion will start to regress spontaneously. That means this enlargement will go off spontaneously because of the bone remodeling. So it is a self-limiting disease. So this cherubism, it can be associated with various other syndromes like Noonan syndrome, Raymond syndrome, and type 1 neurofibromatosis. So these are the various clinical features that are seen in cherubism. Now let's see radiographic features. So cherubism, it is a bilaterally symmetrical lesion, and it, as I told you, it is a cyst-like growths can be seen. So if you see in this radiograph, there are numerous locules, right? That is nothing but multilocular radiolucency, which is seen in both maxilla as well as mandible. Actually, here the early lesions, they start in the mandible, that is in the posterior body and the ascending ramus of the mandible. Okay, so those are there. So first mandible, the lesions will start. And if we see about the teeth, okay, dental anomalies, there will be numerous absence of the teeth will be there, eruption failure will be there, and sometimes multiple unerupted teeth also will be there with the destruction of the alveolar bone. So multiple unerupted teeth and no alveolar bone, destruction of the alveolar bone. This gives rise to an appearance called as floating tooth syndrome appearance. So presence of multiple unerupted teeth with the destruction of the alveolar bone leads to floating tooth syndrome appearance. So this is the radiographic features of cherubism. Next, let us see histologic features. So here histologic features are also kind of different. So here this is a microscopic appearance. Actually the connective tissue will be vascular connective tissue with numerous cellularity. As you can see, too many cells are there. Those cells are nothing but spindle shaped fibroblasts. Numerous spindle shaped fibroblasts will be there. Along with that, as you can see, numerous giant cells are there. So those are all multinucleated giant cells which are said to be osteoclasts, and this was proved by immunohistochemistry markers. And along with that, we can see multiple hemorrhagic areas as well as hemosiderin deposit. Those red spots what you see, that is all is hemorrhage. Okay, along with these features I told you it is a vascular lesion, right? It is a vascular connective tissue, so it contains numerous capillaries which are lined by endothelial cells, and around these capillaries we tend to see this thick eosinophilic perivascular cuffing. That is an important feature. So what all we will see, it is a vascular connective tissue with numerous spindle shaped fibroblasts, multinucleated giant cells, hemorrhagic areas, hemosiderin, as well as capillaries showing eosinophilic perivascular cuffing. And the next condition is cleidocranial dysplasia, which is also called as Mery-Santon's disease. So here this disease is also a hereditary condition which is of autosomal dominant pattern. So here the mutation will be seen in a gene called as core binding factor alpha 1 gene. The main function of this core binding factor alpha 1 is it helps in formation of osteoblasts and differentiation of the chondrocytes. So for osteoblast formation and chondrocyte differentiation. So as a mutation is occurring in this factor only, there will be defect in these two cells, right? So what happens is that as it is a hereditary condition, it results in arrest in endochondral as well as membranous bone formation. So as there is arrest in endochondral and membranous bone formation, during endochondral bone formation, the cartilage has to turn into bone, right? So because of the arrest, the cartilage will not mature into bone. So because of which, whatever the bones which undergo endochondral bone formation, right, they will be showing defect. So what happens is there will be hypoplasia or absence of clavicle bone, and delayed ossification of the fontanelles of the skull can be seen, and some cranial bone abnormalities also can be observed. So all these features can be seen in under cleidocranial dysplasia. So if you see this patient under clinical features, because of the absence of the clavicle, right, the patient has a tendency to bring the shoulders forward till they meet in the midline. Along with that, even the skull also shows frontal, parietal and occipital bone prominency. And also if the x-ray is taken for this patient, paranasal sinuses will seem to be very much underdeveloped. And oral manifestations, if you see here in this picture, there will be underdeveloped maxilla with a narrow high arched palate will be there, and sometimes these patients also can show cleft palate also. Along with that, few dental manifestations will be there, like prolonged retention of deciduous teeth. Because of the prolonged retention of the deciduous teeth, there will be delayed eruption of permanent teeth, and sometimes two opposite scenarios can occur, that is partial anodontia can occur, or there can be numerous supernumerary teeth also can be seen. If you see radiographic features in case of cleidocranial dysplasia, mostly we will hear lateral skull radiographs will be taken. So lateral cranial radiographs, here they show some important features like disproportionately large frontal as well as occipital bones. As you can see here, frontal bossing is there. And if you see the mid face, you cannot see the maxilla or all that part is gone, that is depressed mid facial bones will be there. And if you see towards the occipital bone, there are numerous suture lines, right? So numerous tortuous suture lines which are nothing but Wormian bones can be seen. So these are the various features that are seen in cleidocranial dysplasia. Now let's discuss Marfan's syndrome. Marfan's syndrome, it is also a heritable disease, that is autosomal dominant disorder. So wherein the mutation occurs in a gene called as fibrillin 1 gene. So basically what this fibrillin 1 gene will do is it plays an important role in the formation of microfibrils, which is a feature in elastic fibers. So because there is a mutation in this fibrillin 1 gene, there will be defective or reduction in microfibrils, which are a part of elastic fibers and the extracellular matrix. So as the elastic fiber defect will be there, there will be decreased elasticity of the various areas, which results in overgrowth and instability of the tissues. So whatever features you see in Marfan syndrome, it is because of the defect in the elastic fibers. And if you see in this individual, here normally the defects lie in musculoskeletal, cardiac and the ocular defects. But if you see the skull of the, that is face of the patient, like the shape of the skull and face will be characteristically long and narrow. So that is a very peculiar feature that can be seen in Marfan syndrome. And if you see the body, that is skeleton shows overgrowth, and also if you see in this patient, there are disproportionately long limbs compared to that of the trunk. Along with this, they might even show hyperextensibility of joints with the habitual dislocations, and sometimes arachnodactyly also can be seen. If you see dental manifestations or oral manifestations, high-arched palate is a common intraoral finding. Along with that, there can be bifid uvula, and severe malocclusion can be seen in both the jaws. Along with that, multiple odontogenic cysts can be seen in both maxilla and mandible. So this is in short about Marfan syndrome, and actually this is in detail about the important bone diseases. So both in first part and second part we have discussed about, in this part we have discussed about Paget's disease, cherubism, cleidocranial dysplasia and Marfan syndrome, whereas in the first part we have discussed about fibrous dysplasia and cementoosseous dysplasia we have discussed, and osteogenesis imperfecta. So whatever we have discussed are very much important for essays as well as short notes for exam, and even sometimes smaller questions, very short notes can also be asked, like Marfan syndrome, cleidocranial dysplasia, Noonan syndrome, blue sclera, all these can be asked in very short note questions.